Good morning, everyone. Respected professor, my dear friends. Today I am going to present a seminar on basal cell carcinoma, which is the most common malignant tumor of the skin. By the end of the seminar, we will understand its definition, causes, pathogenesis, clinical features, morphology, diagnosis, treatment. First, let us understand what basal cell carcinoma is. It is the most common type of malignancy in humans that develops frequently on the exposed surface of the skin, the face, and the scalp in the middle aged and elderly persons. The basal cell carcinoma often develops an ulcer that appears to have been bitten by a rodent like a rat, thus, the name rodent ulcer. Basal cell carcinoma, also called BCC, is a malignant tumor arising from the basal cells of the epidermis or hair follicle stem cells. Although it is a malignant, it is considered a locally invasive cancer because it rarely spreads to distant organs. However, if felt unthreatened, it can destroy the surrounding tissue and cause significant cosmetic deformities. It accounts for nearly 70 to 80% of all skin cancers, making it the most common skin malignancy worldwide. It is slow growing and rarely metastasizes. However, it can cause significant local destruction and rarely disfigurement if treated inadequately. This carcinoma does not arise from the oral mucosa and thus is never seen in the oral cavity, unless it arrives there by the invasion and infiltration by the skin surfaces. BCC is believed to develop from the pluripotent stem cells of the basal layer of epidermis as well as follicular surfaces. Now, let's discuss the risk factors and etiology of basal cell carcinoma. Etiology. Ultraviolet radiations are the most important and common cause of basal cell carcinoma, and shorter wavelength UV being the most major cause. A long latency period is required for the clinical onset of the BCC. X-ray exposure as well as chemical like arsenic have also been associated with the basal cell carcinoma development. Syndromes like xeroderma pigmentosa and nevoid BCC syndrome are characterized by multiple BCC occurring in early ages. Other risk factors include fair skin, increasing age, male sex, history of excessive skin exposure, previous radiation therapy, exposure to arsenic, genetic disorders such as Garland syndrome and xeroderma pigmentosa. These are the risk factors for basal cell carcinoma. Clinical features. Basal cell carcinoma occurs most frequently in persons in the fourth decade of life. The male to female ratio is 3.3 is to 2 approximately. It is rare in black skinned individuals and frequent in white skinned individuals. It is mostly seen in the middle third of the face. Now we will discuss about histological features of basal cell carcinoma. Histological features. Histopathological features vary somewhat with subtypes, but most BCCs share some common histological characteristics. The basal cells have large nuclei and relatively little cytoplasm. Nucleoli are large, but they may not appear atypical. Cleft formation, Akar retraction artifact, commonly occurs between BCC nests and stroma because of shrinkage of mucin during tissue fixation and staining. They are very helpful in histopathological diagnosis. The subtypes of BCC are under nodular basal cell carcinoma. Here we can see the diagram of nodular basal cell carcinoma. It is the most common clinical subtype of the basal cell carcinoma. Almost half of all the BCCs. It is characterized by the nodules of large basophilic cells and stromal retraction, that is, cleft formation. Basyloma cells have large hyperchromatic oval nuclei with little cytoplasm. Clinically, it appears as a small, slightly elevated papule with a central depression which ulcerates, heals over, and then breaks down again. Pigmented basal cell carcinoma. Here it is in a diagram. Similar to that of nodular basal cell carcinoma, but with the addition of melanin. The melanocytes are present between tumor cells and contain numerous melanin granules in the cytoplasm and dendrites. Clinically appears as a hyperpigmented translucent papule which may be eroded. Next, now we discuss about superficial basal cell carcinoma. Superficial basal cell carcinoma appears as a bud of basaloid cells attached to the underlying surface of the epidermis. Nests of various sizes often are seen in the upper dermis with palisading pattern. Clinically appears as scaly patches or papules that are pink to red-brown in color, often with central clearing and a thread-like border. Now we discuss about morphiform and infiltrating BCCs. Here we can see the parts: fibrotic stroma, peculiar shape of aggregation of basilar cells, cord of basilar cells, small aggregation in the muscle of erection. It is the more aggressive form of BCC that exhibit pattern results in strands of cells rather than round nests. These thin strands are embedded in a dense fibrous stroma. Peripheral palisading and retraction are less pronounced in this type of BCC, clinically presented as plaques or papules. Ulceration, bleeding, and crusting are uncommon, often mistaken for scar tissue. Now, let us discuss about micronodular BCC. It is same as nodular type with multiple microscopic nodules smaller than 15 microns. Less prominent retraction artifact. It is of aggressive variety, less prone to ulceration and have well-defined border. Cystic basal cell carcinoma presents cystic nodules that may mimic benign cystic lesions. Clinically, these are translucent and blue-gray in color. Now let us discuss about treatment and prognosis. Treatment. Treatment depends on size, location, and subtype. The treatment options include surgical excision of tumor, each lesion treated separately. Prognosis of basal cell lesions is good as it does not lend to metastasis and responds well to treatment. Other treatments are chirotherapy, topical or 5-fluorouracil for superficial lesions, radiotherapy for patients who are not surgical candidates. For advanced or metastatic disease, inhibitors such as vismodegib and sonidegib can be given. Prognosis. The prognosis generally excellent. The cure rate is more than 95% when detected and treated early. Metastasis is extremely rare. However, delayed treatment can lead to extensive local destruction involving cartilage, bone, and adjacent structures. Regular follow up is necessary because patients are at increased risk of developing new basal cell carcinomas. Prevention. The preventive measures include avoid excessive sun exposure, use sunscreen with SPF 30 or higher, avoid tanning beds, regular skin examination, especially in high risk individuals, wear protective clothing and hats. Clinical presentation of basal cell carcinoma. Pigmented basal cell carcinoma. This is, we can say, the nodular basal cell carcinoma. Above the eyes, this is marciform and infiltrating basal cell carcinoma. Red color of superficial basal cell carcinoma. This is micronodular basal cell carcinoma and cystic carcinoma. To conclude, the basal cell carcinoma is the most common skin cancer, although it grows slowly and rarely metastases. It can cause malignant local tissue destruction if neglected. Early diagnosis through biopsy and timely surgical treatment provide an excellent prognosis. Therefore, awareness, sunscreen protection, and early intervention remain the key of successful management. Thank you for the opportunity given by the pathology department. Thank you, one and all.